This is the third part of data sources, institution-based. This presentation was developed by Thien Hancock. Slide 40. We can remember syndromic surveillance. It is collection and analysis of clinical syndromes. Does not require laboratory-confirmed diagnosis. Thresholds for action determined by understanding endemic levels of disease. Goal: to detect signals that could indicate an outbreak requiring investigation long before a laboratory-confirmed diagnosis. Slide 41. This system is sensitive, timely, and simple. It has low specificity. Slide 42. Pacific syndromic surveillance collected data on 4 syndromes: acute fever and rash, diarrhea, influenza-like illness, and prolonged fever, over 200 healthcare facilities in 23 countries. Slide 43. Tally of specific syndromes are collected at urgent care sites and submitted. Syndromic surveillance may require public health staff to collect data. Data sources are individual and service records. It may be passive or active. Slide 44. Reliability answers. What is the consistency of the data collected, quality, coverage, etc.? What is the consistency between sites, individuals? The reliability of syndromic data varies depending on provider, site, and method of collection. Is this a strength, weakness, or neutral? Neutral. The assessment of trends over time help to mitigate the impact of poor reliability. Slide 45. They are the population registries. They are used for a particular condition, for example cancer or birth defects. Each one lacks information on each new case, including characterization of the disease and frequently exposures, risk factors. It is often established at a jurisdictional level. It is used to improve prevention programs, perform public health research, and evaluate health services. Slide 46. The diagnosis of the specified disease is captured through active or passive monitoring systems. It can get additional information for each individual via active review of records, and/or interviews. It uses individual or service records. Slide 47. Relevance provides appropriate and applicable information to meet the purpose and objectives of the system. Is the data collected in disease registries relevant? Yes. Often items collected may initially seem irrelevant, but as more data are collected and analyzed, the data may inform the determinants of disease. Is this a strength, weakness, or neutral? Strength. Slide 48. Tips on hospital-based surveillance. It is focused on monitoring health events in the clinical care setting. It is often used to track healthcare-associated infections, adverse events, and therapy intervention effectiveness. Slide 49. Hospital-based surveillance may include lab reports, environmental testing, chart reviews, but depends on the health issue of concern. It is integrated, active and passive. Data sources are individual, service, and resource records. Slide 50. Does hospital-based surveillance represent the relevant populations? Hospital-based surveillance is not representative of the entire population, but can be representative of the relevant subpopulation. For instance, all patients undergoing hip replacement. Is this a strength, weakness, or neutral? Neutral, depends on the objective of the system. Slide 51. Some conclusions. Data sources for public health surveillance can be broken into 2 main categories: institution-based and, 2, population-based. Institution-based data sources generally have good feasibility, periodicity, and validity. Institution-based data sources are not representative of the whole population. Different types of surveillance systems that utilize institution-based data sources were discussed. Slide 52. Only through careful consideration of your data's origins can you fathom its final relevance. Damien Hoy.